All right, everyone. So we'll go and get started on chapter 18, cardiovascular emergencies. Good stuff. I don't know if this will be one or two videos. It depends on how long I take. But the good thing is, like, we just started this respiratory emergencies, but like we kind of review. You'll notice a trend within these PowerPoints and your book, where we review pathophysiology, anatomy, yeah, or I'm sorry, just straight up physiology and anatomy. Sometimes pathophysiology, and then we'll jump into individual pathologies, right, and what they are and how they present, and then how do we treat them. And that's kind of the general flow of how these things go. So you'll notice this pattern that we go through. So typically, the beginning of the PowerPoint takes a long time because we want to refresh our memory from the earlier chapters on all tracing blood through the heart and all the heart valves and all that stuff. That may not sound very exciting, but it's very testable and it's information that we should know to be good clinicians. So let's go ahead and get started, right? So I will say there's been a really big push within the last, well, really forever, but especially probably the last 5 years, maybe a little longer, 5 to 10 years, about reducing cardiovascular deaths, right? So, in general, this isn't just CPR, by the way, but this is like, heart disease, high blood pressure, blah, blah, blah. But as general, we're trying to make the public more aware of the damages of untreated diabetes and high blood pressure and high cholesterol and all these things that can lead to a heart attack and lead to cardiac arrest. And so, public education by like the American Heart Association and things like that have tried to increase public awareness of cardiovascular disease and cardiovascular health risk. So early access to EMS, of course, we encourage people to call 911. We increased the number of lay people trained in CPR, even just hands-only CPR. I've trained a few hundred people in just hands-only CPR. It takes like 15, 20 minutes. Actually, I've trained I think it was around 800 fourth graders, or maybe there's sixth graders. I don't remember. Whether for college, every year we'd go out there and train them on STEM day, like where they learn about science. And anyways, so we increased the number of defibrillators in public buildings, and people need to know how to use them, even though they're automated. There's still a little bit of training that's helpful, right? We recognize the need for ALS services. So, unfortunately, you're going to notice in this chapter, EMTs still play a pivotal role in this, but paramedics really start jumping into like antiarrhythmics and certain type of chest pain treatments and protocols. But EMTs still give oxygen, nitroglycerin, and aspirin when we treat these patients. So it's still it's still very pivotal role in this. And I'll talk more about that. But anyways, we also have coronary catheterization centers. So basically, I'll show you what this looks like in a bit. But basically, this is where they go in there and they'll inflate a little balloon and put a mesh, and they'll try to open up this clogged up vessel, right? So like the little snake thing that they'll shove down the toilet to go pick up someone's giant dookie. It's the same thing in the coronary vessels, right? They'll go in there and they'll try to pull out that plaque or stent it, or so you're basically unclogging a pipe. It just so happens it's a blood vessel wrapped around the heart. So anyways, that's kind of what we're trying to do to reduce cardio. The big one. So high quality CPR is obvious, that would save lives. But even just us tracking like the CARES registry, right? The cardiac arrest. I don't know what CARES stands for, but it's a registry where you put cardiac arrest data in there, and you can compare your metrics within your agencies versus the county versus the region versus the state versus the nation versus the Midwest, Southwest, whatever. So basically, you can look at your metrics compared to the rest of the country, and that helps us identify trends of, oh wow, Parker County Hospital District has really high cardiac arrest survivability rates. What are they doing different from us? And then so you can look and kind of figure out. So anyways, there's a lot of research going into this. So it's exciting right now. I think it's exciting. So real quick anatomy review. Where does the heart sit? It sits in the center of the chest, right up underneath the sternum, in the mediastinal space, right here. Now, with that said, this is the patient's right, and this is the patient's left. And so what you have to realize is the heart really does sit in the center of the chest. It's just a chunk of it will shoot off to the left. And so really, if you're looking, if you ask yourself, this is an interesting test question. Okay, this guy gets into a loco fight at the bar, and he gets stabbed right there in his chest, right? What is the anterior portion of the heart? Students get this wrong. What is the anterior portion of the heart? Meaning, what is the forwardmost portion of the heart? Is it the right atrium? Is it the right ventricle? The answer, it's the right ventricle, okay? So the right side of the heart is the one that's sitting forward. Okay, I know that's kind of weird. You're like, what, Hunter? I thought the right side of the heart was like, well, it is, but Just letting you know, this area right here, that's the right side of the heart. And behind that, for the most part, is the left side of the heart. I don't make the rules. I'm just letting you know that generally if someone would be stabbed in the chest like that, it's typically the right side of the heart, specifically the right ventricle because it's larger. So, of course, we have two lungs on the right side. Remember, we have three lobes. On the left side, we have two lobes. You know, the diaphragm, it's the muscle that controls breathing. Of course, we know when we breathe in, or when muscles contract, they shorten. So it goes like this, and it sucks air in, okay? So we'll name off some important vessels right here. So these blue ones, what do you think these are? What do you think this blue vessel right here is? It's the vena cava, okay? So this happens to be right here, the superior vena cava. And this is like the external jugular and internal jugular and blah, blah, blah. It doesn't matter what those are, but just letting you know, that's venous blood, so deoxygenated blood coming to the right atrium, okay? And you hear me talk a lot about the inferior vena cava, but there's a superior vena cava as well, right? That goes from here up and supplies all this, and the inferior vena cava, for the most part, does there down, okay? And then, you know, you have the aorta and all the branches of the aorta, like the brachial vein, brachial artery, and subclavian and all that stuff. So anyways, that's kind of general anatomy. That's just really gross anatomy that you probably should know at this point, hopefully. So we're just going to talk about the layers of the heart. Sometimes they do ask about these because, of course, as we know, there's pathology in each of these layers, and we have to know what they are. So you've probably heard of a MI, right? A heart attack is called an MI, a myocardial infarction. What they're talking about is the actual muscle of the heart, okay? This happens to be the middle layer. So, you know, like this down here is the myocardium, okay? It's skeletal muscle. It's not smooth muscle. It's not skeletal muscle. It's cardiac muscle, right? So it's a different type of muscle. It's found in the heart. It's similar to skeletal muscle, as in that it's striated, but it is not the same. And so what you end up with is a thick layer of muscle called the myocardium. And as we know, the myocardium has lots of mitochondria. It requires a huge amount of oxygen demand. Within just about 3 to 5 minutes of not receiving oxygenated blood, the tissue will become ischemic and then fart and die. And we know that myocardium does not regenerate. So once the damage is done to the myocardium, it's done forever. You're never getting it back. So those are some general principles, okay? Now, the pericardium, this is this thick fibrous sac that that surrounds the heart, okay? And so it's like a sac, and there's pathologies that we see in this. One of them, pericarditis. Remember, pericarditis is chest pain that is relieved when the patient leans forward. I'll just explain why that is. So you can get a viral infection. It's typically almost always, not always, but almost always a viral infection that will cause this, or most commonly, I should say. There's a few other ways you can get it. And basically, the lining of the outer layer of the heart can get inflamed. And so basically, as the heart's beating all day, it rubs and it can create this friction, and that causes a sensation of pain. Well, interestingly, when the patient leans forward, right, so the patient will lean forward, their chest pain is relieved. So the hallmark of pericarditis is chest pain that's relieved when the patient leans forward. And how that presents typically on exams is it'll be in someone less than the age of 35, and they'll say that they're having chest pain, you know, right in the center of their chest, it's a sharp pain, but it's relieved when it leans forward. That's pericarditis. So does that affect the muscle? Is that a heart attack? No, it is not. It's not the same thing, right? It is pericarditis, okay? And then, and then we have a visceral layer of the heart, okay? So this is called the epicardium, or the visceral pericardium. That's right here, okay? So this is the outer layer of the heart, okay? So as you can see, let's just zoom in, enhance. You can see the muscle, right? And then you have this little sac, or like it's like a wrapping almost. It goes around the outside of the heart. And then we have this pericardial space. There's a little bit of fluid in there that provides lubrication. And then we have the actual pericardium, okay? So in order, if you were to work all the way inside of the heart, right? Like right here is, let's just act like this is your right ventricle and there's blood in here, okay? So where does the actual blood touch? It's the endocardium, okay? So endo, inside. And then we go to the myocardium. The word myo means muscle, so the muscle part of the heart. And then we go to the epi means outermost, right? Epicardium, right? So the outer layer of the heart, and then you have the pericardial space, and then you have the pericardium. Okay, I know those words sound very similar, but if you break them down, they might make a little bit more sense. I don't get super pedantic on testing you on those layers, but I'm just explaining that to you. Um, so each atrium receives blood that is returned to the heart from other parts of the body. Sure. So where does the right atrium get its blood supply? Get its blood, right? Where's that blood come from? The vena cava. So it's venous blood that's coming from the heart, from the lower extremities, wherever it's coming from. And then where does the left atrium get its blood? Think about this. Where does the left atrium get its blood? It's the pulmonary vein, right? The pulmonary vein brings oxygenated blood. What? A vein bringing oxygenated blood to the left atrium, okay, from the lungs. It's already been, diffusion has taken place and now it's oxygen rich, okay? And obviously the ventricles will pump blood out of the heart. So where does the right ventricle pump? To the lungs. Where does the left ventricle pump? To the aorta, which will go up to your head and down to your big toe, right? So you should be able to explain those things hopefully by now. We talk about this a lot. So let's talk about valves of the heart. You actually do need to know 4 of them. Well, there's really only 4, but you need to know the 4, okay? So remember the saying, try before you buy. And when we read, we go from right to left, right? So like if I'm looking at the screen, it's right to left, okay? So tricuspid valve is first, okay? And then it'll go to the mitral or bicuspid valve, okay? Remember, mitral and bicuspid means the same thing. I don't care which one you use. You just need to know that they mean the same thing. Now, there's the 2 valves that I just named is, remember, tricuspid, that's on the right side, and then the mitral or bicuspid, and this is on the patient's left. And so here's what you need to know about these is that they're thick valves, and you're like, well, golly, Hunter, why do they call them that? Well, the reason is the word tri means 3, okay, like a tricycle. So you can notice there's 3 components of this valve. 1, 2, 3. So there's 3 components, and that's where they came up with the word tricuspid. And then the mitral or bicuspid valve is made up of 2 valves, and that's where they came up with, bicuspid, okay, or mitral. So that's where those came from. And these atrioventricular valves, I know that sounds like a scary word, but really think about it. They're right here, right? They're separating the atria from the ventricles. That's what they do, okay? So remember, try before you buy. And that's, if they ask you how many components of the valve there are, try 3, buy 2, like a bicycle or tricycle, okay? Now, there's these things that we don't talk a whole lot about, but there's a lot of pathology with one of these, called semilunar valves. And the word lunar means moon, right? So these are kind of like semi-moonish like valves, right? So they're like kind of like moon valves. And if you zoom in, I guess if you're drinking a lot of beer, you might think like, oh, that looks like a moon. But I didn't come up with it, okay? Don't take it up with me. But these are these valves that we need to know about, called the aortic semilunar valve and the pulmonic semilunar valve. And so the pulmonic semilunar valve is on the patient's right, okay? Because it's taking blood from the right ventricle to the lungs, okay? And so this is fairly low pressure, just jump, it's a very quick trip from the right ventricle to the lungs. So it doesn't have to pump super hard. So the right side of the heart is considerably thinner than the left. And there's pathology that happens here, but it's not as common as this one I'm about to talk about, called the aortic semilunar valve or the aortic valve, right? Lots of pathology here, right? Like aortic regurgitation, aortic stenosis, a bicuspid aortic valve, right? Like there's all these pathologies that create problems, especially in older people with jacked up aortic valves. And so what happens is the left ventricle pumps blood out of the left ventricle into the aorta. Well, before it can go into the aorta, it has to push its way through this valve. These are one-way valve, guys. So it's shoving blood through the valve, but then since the way the valve opens is like this, but when it closes, blood shouldn't be able to come back down this way. So that's the idea of these valves, by the way. All these valves I'm naming right now, they're one-way valves. So blood can go out, but it shouldn't be able to come backwards, okay? And so as you can imagine, if this valve becomes aortic stenosis, it becomes hard. It's really hard to pump blood out of the left ventricle because you're pumping up against a rusty valve that doesn't like to pop open. Or if it's a leaky valve, If like when it's closing, instead of closing tight like this, it closes like this, and all that blood just kind of leaks back in to the left ventricle. That's called aortic regurgitation, and it has its own set of problems. And a lot of times, these people have to have their heart valves replaced in both of the scenarios I just named. So just later on in life, they'll get them replaced. But what I'm saying is these create pathologies, and that's why we need to know them, okay? And then we also have these papillary muscles in the ventricles that contract to tight the chordae tendineae. What? That's these. You might see a little bit here, and these kind of like pull. They kind of like here, like here's where they have them drawn. They kind of like pull on them. Like I don't know how to describe that. It's almost like they pull them tight, pull them taut. So, for a fun little exercise, say it with me. Let's trace a drop of blood up from your brain all the way back to your brain. Okay? Well, so we can start up here in your brain, and it's going to come eventually down through your external jugulars and then into your, or your jugular veins really, into your superior vena cava, right atrium, tri before you buy, so tricuspid valve, right ventricle, pulmonary artery, lungs for diffusion, comes back in the pulmonary vein. Now it's oxygenated. Notice how it's red. Into the left ventricle, through the bicuspid or mitral valve, from the left ventricle into the aorta. From the aorta, it'll go up into your carotids and eventually up into your brain. So that's the order, right? And we should be able to do that. And I just left out two of the valves we just studied. So let's try this one more time, but I won't say anything, right? Vena cava, right atrium, tricuspid, right ventricle, pulmonic semilunar valve, pulmonary artery, lungs for diffusion, oxygenated blood back through the pulmonic vein into the left ventricle, or I'm sorry, into the left atrium, mitral bicuspid valve, left ventricle, aortic semilunar valve, and then out through the carotids. So those semilunar valves, they're worth knowing, okay? Of course, you're not going to listen to someone's heart, as an EMT and be like, "Oh my God, you have aortic stenosis," right? That's not really the goal here, but you need to know that what those valves are. Okay, there's just really there's more. What we just need you to know at least these four. Okay, all right. Now coronary circulation. You heard it here first. Don't memorize this. I just put this down here for a reference so it can explain it. Is that don't memorize this. I don't need you to memorize what these are. Is we have these coronary arteries, okay? And you'll hear about coronary heart disease or coronary vessel disease or So what happens is the heart is wrapped up in in their very own special arteries, okay? And they gave them a weird name. They called them coronary arteries, okay? And there's like 4 or 5 of them, and they each supply different sections of the heart, right? So like there's a coronary artery, there's one, right? There's one. You know what I'm saying? So these are coronary arteries. And what do arteries do? They bring oxygenated blood in most scenarios. They bring oxygenated blood to the muscle. And so, as you can imagine, if you get a big old chunk of fat and diabetes, not really, but fat, chunking up this section of the vessel and it completely blocks it off, the remaining of this chunk of the heart is now not going to have oxygenated blood and it's going to die. That's a heart attack. Okay, so let's go back. This is just a general pattern. Do not memorize this. It's complicated. Of like just as like the right coronary artery supplies the right side of the heart, right? And these are just general things that you might, I just want to point out that there's these certain vessels that we call coronary arteries that are wrapped up around the heart in a very specific pattern, and they provide certain sections of the heart with blood flow. And that is the coronary artery system. Now, something I do want you to know is, think about this. Think about this. When do you think these vessels perfuse, right? You think it's when the muscle's squeezing down and real tight in systole? Or do you think it's in diastole? When the muscle is relaxed? It's in diastole, okay? So there's a reason for this. Sometimes you want to slow people's heart rates down or, increase the length of diastole, and there's a few other things. But realize that, test question, when do coronary arteries perfuse the heart? It's in diastole. Okay, it's very important that you realize that. So think about this. If the heart's beating 150 times a minute, how much time are you spending in diastole compared to if the heart's beating 70 times a minute? Not a lot of time. So you want generally in a heart attack a slower heart rate, not only because you consume less oxygen with a slower heart rate, but and nutrients, but you're diastole longer. So that's a general principle we use with one of the medications that paramedics give and physicians and stuff. So just kind of wanted to point that out. Again, I don't give a shit if you you memorize these. I don't think it's a good use of your time. Um, I don't even have them. I mean, I have them for the most part memorized. I could point them out, but it's not that important right now in your training. Now, so the heart. So uh, realize that a blood vessel is not the same thing as a coronary artery. Coronary arteries are their own little arteries that supply the heart, not to be confused with the vena cava, the aorta, the subclavian, right, the brachial, whatever, carotids. Those are different. Okay, so of course, carotid arteries are a blood vessel, but when we start talking about blood vessels as they relate to the heart, we're not talking about the coronary arteries. We're talking about like the vena cava or the pulmonic vein or something weird like that. Okay, so just be aware they're very similar, but they are slightly different, right? To where when you hear the word coronary arteries, I want you to think, that's the artery, the vessel that provides blood to the muscle portion of the heart. Okay. So we've talked about tracing this through, tracing a drop of blood through here. You need to be able to do that. We've talked about that over and over and over again. So this is one of those things that in class, there's going to be a day, it's coming up, where I'm just going to hand you a piece of paper and say, start from the big toe or start from the inferior vena cava and trace a drop of blood back to the inferior vena cava. You're going to have to be able to do that, okay? It's expected of you in EMT school. And it's not even us being difficult or trying to flex on you. You need to know that. Now, general review of what blood components are. So we know that, I took a little picture here, right? The majority of so it's just called like hematocrit, right? But the majority of our blood is made up of plasma, right? So this is like this, you've seen this like after a wound heals, you'll see some like a yellowish stuff on top of the wound, like a liquid. That's plasma. And so plasma is like this it really is that color, straw colored substance. It carries some nutrients in it. It's very watery, but that's like a major component of our blood, right? And then we also have, of course, red blood cells. What are red blood cells made up of? Hemoglobin, right? Remember, hemoglobin is rich in iron, and hemoglobin is where oxygen binds to the hemoglobin itself, and it's carried around the body, blah, blah, blah. Okay? Now, we also have these white blood cells and platelets, and these generally make up less than 1% of the total blood, especially if you're not sick. And so, remember, what are white blood cells that look like this? Right? Remember, white blood cells are the little Pac-Man guys that go around the body just looking to pick a fight with any foreign invaders, and they'll go up there and either like nuke the plate, like they'll like just do like a suicide vest and they'll just blow up and try to kill everything around it that's bad, and or they will just chew on it like a Pac-Man, right? Or they'll do both. So there's variants. I know I give the acronym of like they're Pac-Man guys, and the majority of them do that. But sometimes what they do is they just carpet bomb it, just like bah, 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 and they just start dumping granzymes and radicals, right, to try to kill whatever it is they're going after, usually bacteria in this example I'm giving. And sometimes they'll just blow up, right? So they'll just poof. And so I'm giving an example of like a carpet bomb or a suicide vest guy, not to be insensitive, but that's one way to look at this is that they're going in there to fight a war, right? Like they're trying to keep your body safe, and that's what they do. All right, now this is a good example of different white blood cells. We should point out there's different white blood cells, right? Like you notice how this one looks different than that one, and then that one. So just to be pointed out. Remember, what's the shape of a red blood cell? It's a biconcave disc. It really does look like that underneath a microscope. Okay, these are platelets, by the way. We're going to talk about the pathology of platelets and the issues they cause in heart attacks because we treat it with aspirin. Now, the heart electrical conduction system, this is very rudimentary, basic information that I actually want you to know, okay? So there really is electricity running through the heart, okay? The heart has its own electrical system, okay, that does its thing. Now, one thing that they love to test, even at the EMT level, right, is where does electrical impulse start? What's the origin of electrical impulse, right? And it's called the sinoatrial node, okay? So if I were to draw a heart, right, here's the four chambers, here's the right atrium, Here's the right ventricle, left atrium, okay? You'll be like, oh, wow, Hunter, what a great drawing. But right here is this thing called the SA node. And that means sinoatrial node. And it's in the right atrium. And what it does is it sends these impulses through the atrium, okay? And then eventually these impulses meet this little thing at the AV node. What's the word AV? Atrioventricular. At the junction of the atrium and the ventricles, there's another node, right? And so then it goes to the AV node and it'll come down into this guy called to the bundle of his, and then Purkinje fibers, right? And so you're like, God, Hunter, I'm not in paramedic school. I get it. It's annoying. It's frustrating. But I'll recapitulate. So please understand this. Electrical impulse. This is normal. What normally happens. Electrical impulse starts in the sinoatrial node, the SA node. That's what's normal. Where's the SA node located? The right atrium. Okay. It'll depolarize, or it sends its signal out to the top part of the heart, the left and right atrium, and then that signal makes its way down to the atrioventricular node, which is at the junction of the atria and ventricles right here. And what happens is that little area will hold the impulse for just a minute, and then it will send it down into the bundle of his, and into to the bundles, and then the bundle of his and Purkinje fibers, right? So it's very coordinated. This is very coordinated, and you're like, well, why do you need an AV node? Like, that's weird. Well, the reason you need an AV node is if you sent electricity to every cell within the heart all at once, it would just like slam together. And that's not a very effective pump. We know that the heart beats boom, 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 boom. And what makes the little gap between the first boom at the top of the heart, the SA node, and the gap at the bottom of the heart when the ventricles contract is the AV node. It's a little stop sign that says, whoa, 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 I'm going to hold this impulse for just a second to where now I'm drawing blood. Stay with me. Now I'm drawing blood. To where when I dump my right atrium blood into the right ventricle, there's enough time for it to completely dump in there and fill before the ventricle contracts. So I know this sounds complicated, and I wish I had an easier way to explain this to you. And there's a lot of videos on YouTube. If you get lost in this, you're not going to be crazy heavily tested on this, but it is something that I think you should know. And so basically, that is how the heart beats, okay? Let's see. Oh, dummy, there's a big old picture of it right here, and I'm like giving you all a terrible drawing. So let's go over it one more time. Where's the SA node? Right? It's in the right atrium. Okay, it's right here. And then so we start up here at the SA node, and it goes through the right atrium and the top of the both atriums, right? The left and right atrium. And so they both contract and they dump their blood fairly low pressure, very short trip from here, from the right atrium to the right ventricle, and the left atrium to the left ventricle. So they just don't have to squeeze very thick. Notice how it's pretty thin muscle up here, right? You don't have to squeeze very hard to go like from here to there. It doesn't take a lot of muscle. And so what happens is it'll dump its blood into there when it squeezes, and then this electrical impulse stops right here at the AV node. Remember, this is the stop sign of the heart that's like, wait just a minute. Now you can go. And so what happens is it holds the impulse for just a minute into the the bundles, and then to the bundle of his, and then the Purkinje fibers. So just know that there's a system that we use. Obviously, there is a huge amount of medications that can influence this, and factors that can influence how this works, and there's pathology every bit along the way of what I just described. So, and obviously that creates problem when your heart doesn't have the right electricity function, like things tend to not work very well. So just be aware, okay? Now, the interesting thing about cardiac cells is you remember I told you that, there's cardiac cells and there's smooth muscle and there's skeletal, right? Cardiac cells are their own little thing. Now, I will say they are very similar to skeletal muscles, at least in physical appearance, but they behave differently. And one of their behaviors is excitability, right? So cardiac cells have this ability, right? Electrical property, right? Called excitability. And it's the ability of cells to respond to electrical impulse. Okay, yeah. Makes sense that a cell that responds is excitable. So excitability. And then there's conductivity. So they have these special junctions in between each cell that allows the cells to conduct electrical impulses. So electricity travels really well with the way that we have heart muscles cells aligned to jump from one cell to another in an organized fashion. Okay? That's conductivity. You should know what conduction is. And automasticity, this is weird. You're like, what? Automasticity is the ability of cells to contract without a stimulus from a nerve source. And you're like, wow, that's really weird. And it's because we have this thing called cardiac escape, right? So the The heart cells generally are told what to do by the nervous system. Okay, they're supposed to. But what can happen is when those systems fail, the heart has the ability to react without being told what to do so without from a nerve, okay, from the brain or the nervous system. And so you're like, wow, that's really weird. That doesn't really happen almost anywhere else, right? And it really doesn't. So that's what makes it unique is this thing called automaticity is to where the heart can kind of do its own thing if it wants to, okay? And that's called automaticity. And I'll just explain something. You don't memorize this part, but it's worth knowing. What was cardiac escape? So basically, you should know that if the sinoatrial node or the SA node, the primary pacemaker of the heart in the right atrium, fails, then it's like, all right, the AV node will take over. And if that fails, it's like, all right, the ventricles will take over. If the ventricles fail, you die. So there is like a built-in system within the heart, and this is like that whole automaticity thing. Well, it plays into that a little bit to where if it keeps us alive because it's actually not uncommon for this one to fail eventually, and so I'd say probably 1/4% of the population have issues with this node. Right? If you ever heard someone has atrial fibrillation or AFib, it's sometimes related to this. And so just be aware, like these are all things that we could know. That's called cardiac escape. When one portion fails, then the bottom one will take over. When that one fails, the next one will take over. When that one fails, you're dead. So you have like this system that you can kind of work through and try to stay alive. Okay? So we'll just talk about general physiology. So remember those annoying words: chronotropic, dromotropic, inotropic. Chronos time, dromo speed of conduction. Inotropic is like the force of conduction, right? And they're controlled by the autonomic nervous system, right? So like this automatic system of the heart. And what's the autonomic nervous system, right? Sympathetic, parasympathetic. Sympathetic, we're about to go fight a bear, big fast heart rate, lots of blood. Parasympathetic nervous system, you just ate too much CCs and now you need to take a nap, right? Heart gets nice and slow. So that's the two systems and they're constantly fighting each other. Now, with that said, the endocrine systems, right, it certainly does, actually it does. It does play a role in the heart and how fast it beats. A really good example of this would be the thyroid. If you have hyperthyroidism, you'll almost always have a fast heart rate. It's one of the giveaways of it. Okay, and then the heart tissue itself can uh, yeah, the heart tissue itself. Now, receptors constantly monitor body functions to maintain homeostasis. So we have chemical receptors, right, that are measuring how much blood, how much CO2 is in the blood, what's the pH of the blood, how much oxygen's in the blood, right? That are all measuring the chemical properties of the blood. But we also have baroreceptors that are measuring the pressure within the blood vessels, and that helps the heart determine, beat faster, beat slower, blah blah blah. So there are receptors that are constantly feeding back to the heart and saying, "Hey, do this, respond in this way to make it better." Okay. Well, I just said this, right? Baroreceptors respond to change in pressure. So baro is pressure. You should know that. It's like a prefix. And then chemo sounds like chemical, right? Like chemical. So chemoreceptors changed into the chemical composition of the blood, namely pH, right? Like the pH of the blood and CO2. That's really largely what they look at is the pH. Now, the cardiac cycle, right, begins with a myocardial contraction and concludes at the beginning of the next contraction. Oh, wow. So it starts with one heartbeat and ends when the next heartbeat starts, right? So that's a cycle. So we've talked about this over and over again, but systole, remember, this is when the bottom of the heart contracts, okay? And or it's really any part of the heart, but we think about the bottom part of the heart. But it's when it contracts. This is muscle contractional systole, and diastole, right? This is relaxation. You just want to lay there and die, right? Just relax, right? So diastole is relaxation of the heart. What phase does the coronary arteries perfuse the myocardium? I just told you this. It's diastole. It's diastole, right? And these are time based, by the way. So you spend about 1%, 1 to 2, right? So we'll just break this into seconds. You spend out 1 second with your heart contracting, and then you'll get 2 seconds with the heart relaxing. So it's a 1 to 2 ratio. It's not a ratio actually, because it's over 3. So I should make this simple, right? This 33% of your time is spent in this, and then 66% of your time is spent in this. And this becomes important because of a formula called MAP, mean arterial pressure. Now, we've talked about this a lot, but I can talk about it some more. Notice that we keep talking about it, so you probably need to know it. Called preload. Remember, preload is the amount of blood that's returned to the heart that's about to be pumped out. So, how do we increase preload? IV fluids is a really common way we do this. How do we decrease preload? A drug called nitroglycerin. I'll explain why. But remember, as the ventricle is loading up, it's filling up during diastole. How much blood makes it into that ventricle prior to it contracting? That's preload. Okay. And then afterload is we got this really full ventricle. Now, when it starts squeezing, how much does it have to, like, how hard does it have to pump to eject blood out of the ventricle through the semilunar valve into the aorta and up to your head and down to your toe, right? Like, how much is it resisting? Like, how much squeeze is it facing? Is it against to be able to get out? Okay. Stroke volume, this is the amount of blood that's ejected per contraction. It's around 100 to 150 milliliters per beat. And then cardiac output. So think about this. Cardiac output. How much is your heart putting out in a minute? Okay. And so what you do is you take stroke volume. You'll never have this number pre-hospital. It's done inside the hospital with a machine times the heart rate. And then you can figure out, okay, the heart's putting out like 1.5 liters a minute or whatever the number is. Okay. So yeah, those are formulas. Factors that influence the heart rate, the stroke volume, and both will affect cardiac output and perfusion. So, what are some of these factors? What are ways we can increase cardiac output? Well, as a generality, if you increase heart rate, you can increase cardiac output, right? Okay, we just looked at this formula. Like, it would make sense if you increase this number and multiply it times the same number, it's going to be a higher number over here, right? Another way you can do this is increase stroke volume. Okay, and so it makes sense, right? If you increase this number and you leave that number the same, then this number is going to be higher, right? Like very intuitive math here, right? And so there's a few other ways you can affect this too, but that's how you can affect cardiac output. And you're like, well, why do I need about cardiac output? Well, we use cardiac output as a general rule of perfusion that if someone has half the or a third even of the cardiac output that they once had, then they're going to have shock, right? Like if your heart right now, if I said, all right, student's heart, it can only shoot out a third of much blood as you're shooting, as you gave out in the previous minute. You're going to have symptoms. You're going to have problems. Like you're probably going to be unconscious pretty quickly. So just know that that's why we look at this is because sometimes we gauge like, oh, wow, they have poor cardiac output. Realizing the consequences that causes, namely shock, right? Hypoperfusion is shock. So that's why we look at that. That's why we care. Okay. Now, what's Starling's law? I've talked about this a lot, but there's a law of it's like a physics law that says the greater the stretch of the muscles of the heart, the more they stretch, the more they contract. And so I think of it like a rubber band, right? If I were to take a big old rubber band, the further I stretch it, the greater it's going to contract when I let go. Well, cardiac muscle is the same way. That the greater you stretch a cardiac muscle, so the more preload, the more shit you pump into the heart, the harder it has to pump to eject that out, and the harder it will pump to eject that out. And that's called Starling's law. Okay, guy got it named after him. And you're like, well, cool story. What's important about that? Well, the reason we need to know about Starling's law is nitroglycerin. Nitroglycerin uses this law to its advantage. So nitroglycerin decreases preload, okay? So we know that like 70% of our blood is stored in the veins, right? Well, if you cause venous dilation, and instead of holding 70% of the blood, now it's holding 80% of the blood, just sitting in the veins, that means there's 10%, quote, 10% less blood making it back to the heart because now it's not really it's just sitting in the vessels. It's not really going through the heart, it's just sitting in these really opened up vessels, right? Water hose went from this big to this big, so now there's just like this static blood in these blood vessels. And so, especially on the venous side, right? Veins have a large, what's called a capacitance. They can take on a lot, they can expand a lot to take on a lot of blood. And so, what we do is we give this drug called nitroglycerin, and it causes venous dilation on the venous side of the house. And when that happens, you decrease preload. And when you decrease the amount of preload, also known as the amount of blood going into the heart, you decrease the stretch. And when you decrease the stretch of the heart, you decrease the amount of energy it's going to take to need to slam the muscles back together. And we know even when it's stretched out, in order for it to go from here to here and squeeze back together and contract, just like a bicep, that takes oxygen, and that takes glucose, and that takes ATP, right? And so what we're doing when we give nitroglycerin is we're saying we're just going to use Frank Starling's law. The heart's not going to stretch as wide, so it's not going to have to use as much oxygen and glucose to produce ATP to have that muscle contraction. And so that's what we're doing when we give nitroglycerin, is we're just saying, all right, fine, we'll reduce the oxygen consumption of the heart because we won't let it get as full and squeeze as hard. So that's kind of the principle of that. Now, ejection fraction, I've talked about this before too, but this is the percentage of blood pumped from the heart with each contraction. So, contrary to sometimes like with my little ghetto animations, is the heart doesn't actually squeeze completely shut. It will squeeze about like 80, 70, 80, 90% of the blood out. It doesn't actually squeeze 100% out, right? That's not very effective. So we can measure this again with a machine in the hospital and be like, oh, wow, like this patient has 20% ejection fraction, meaning you fill up, I'm just making up a round number here. The ventricle fills up with 100 milliliters of blood, and when it contracts, it only squeezes out 20 milliliters of blood, not very much blood. That's an ejection fraction of 20%. You just ejected 20% of the blood. And that's not good. Like, that's not good for the patient. And so, because they're not going to get enough blood. So they'll have signs of shock. And so this is ejection fraction, and that's kind of why we know that. We use this as like a marker of heart failure, right? So if someone has a poor heart or not a good heart, we can look at it and be like, oh, wow, their ejection fraction is really low, and they may need a heart procedure, or we're going to add medications to it, or whatever we're going to do to try to treat their heart failure. Ejection fraction becomes a problem with heart failure. Really, when you hear ejection fraction, especially low ejection fraction, you should think, oh, wow, the patient has heart failure. We're going to talk about what heart failure is. So what is, blood flow within the heart? So blood is returned to the heart from the upper body via the superior vena cava. I've told you this. And the lower body is brought through the inferior vena cava. They meet, right, and dump into the right atrium. Oxygenated blood is returned to the left atrium from the pulmonic vein. What? Oxygenated blood through a vein? Yes, I point this out a lot because students get lost on that. Deoxygenated blood is returned to the heart via the veins. Well, see, this pisses me off because they say that, I should have taken this piece out. Well, it does, but with the exception of the pulmonic vein, it's oxygenated blood. And this is why students get confused. Anyways, pulmonic circulation, or the pulmonary circulation, right, carries blood from the right side of the heart to the lungs and back to the left side of the heart. So what vessel carries deoxygenated blood from the right ventricle to the lungs? The pulmonic artery. It's carrying blood away from the heart. And then and they go to the lungs for diffusion, and they come back through the pulmonic vein. Remember, veins carry blood back to the heart. So it happens that the pulmonic vein will go to the left atrium. Now, systemic circulation is responsible for blood flow to the rest of the body, of course. We've talked about that. And the systemic arterial circulation, so oxygenated blood leaves the heart through this thing called the aorta, right? But in order to go into the aorta, remember that pesky aortic valve, right? It has to go through there to get into the aorta, okay? So it's a one-way valve that, like I said, has lots of pathology. So cardiac cell ischemia. Let's talk about this. So the word ischemia means needs more oxygen. Okay, it's not dead yet, but it's getting pissed off. It's like, I really need some more oxygen. So you'll have pain in cases of ischemia. But what happens is, when your heart doesn't get enough oxygen, it'll produce pain, and there's a reason for this. But so you produce pain. It produces a sensation of pain, and really, when you restore blood flow, or you increase the amount of oxygen, or you decrease the demand of the heart, that pain can go away pretty quickly sometimes. So, chest pain, right, is related to cardiac cell ischemia. How do we get ischemia? There's lots of ways we can get ischemia, right? If you were to go run to the stop sign and back 10 times and you're not conditioned for it, sure, you could have ischemia. If you have a heart attack, sure, you could have ischemia. If you have heart failure, sure, you could have ischemia, arrhythmia. There's a lot of ways we can get cardiac cell ischemia. But that's worth knowing, right? So ischemia is the cell. My handwriting's terrible, so forgive me. But ischemia is the cells are starving for oxygen. Okay? Versus infarction, the cells are dead or dying. Okay? They're going to die. They're dead. And so you're like, oh, okay. So that's why we call it a myocardial infarction. You're right, because the cells have already died. And do cardiac cells regenerate ever in adults? No, they don't. So remember, when these cells die, they're done. Kapooey, goodbye. So it creates this thing called heart failure, which we're going to talk about very soon. But that's a distinction I need you to know. Ischemia, cells are screaming, saying, "Please give me oxygen. I'm dying over here, starving." Infarction, the cells have died. Okay, so which comes first, ischemia or infarction? It's ischemia. And then if that's untreated, it'll progress to infarction. Okay. Now there's an interesting thing called atherosclerosis. Say it with me: atherosclerosis. Atherosclerosis. Beetlejuice. Beetlejuice. No, I'm just kidding. Atherosclerosis. You should be able to know this. The students look at that word and they're like, apropera. It's atherosclerosis. And I'm glad you asked. We can break down what this word means. Athero is meaning relating to arteries. And then we have a anytime you hear the word sclerosis or sclerotic or anything, it means stiffening or hardening of. Okay, and so this is basically saying hardening of the vessels. And you're like, okay, well, okay, okay. Well, what's happening in atherosclerosis is okay. Let's just start at the very beginning with my drawing down here, and this will make sense. You don't need to know all this. I just you do not need to know that, so don't memorize that. What I do want to do, this is a really good picture here. This is a normal artery. Okay, we have arteries everywhere. All right, and what happens is you have this thing called the endothelium. It's the inside of this water hose, this artery. For whatever reason, it gets broken. A really common way this happens is high blood pressure. And think about it. Like if you have a water hose and you pump like a really high pressure in there, it's gonna tear. It's gonna have like these little micro tears. And you're like, oh, okay, I can imagine that happening in my body. Like if it gets really high pressure in there, you're gonna tear something. And so you get a little bit of a tear. Okay, this happens in everyone. I'm in my late 20s, and this has already happened to me, right? Like this happens to everyone. So calm down. But those that have high blood pressure, this becomes, it's very acceleratory. It's a big issue. Okay. It's what causes the problem, okay? And so, normal artery, what happens for whatever reason, you end up with a tear on the inside of your blood vessel. Okay, well, that's a problem. Well, what happens is you have these little white blood cells will go in there and be like, oh, there's a tear, we should fix this. And so they go in there and they do all their inflammatory nonsense, and they think they're being super helpful and they're high-fiving each other, but you get this cholesterol called LDL, right? It's the bad cholesterol. And it goes, and it's like, oh, cool. It's just, remember, cholesterol is just floating around in your blood. And it's like, oh, cool. This seems like a cool place to hang out. There's lots of inflammation here. I'm just going to like go up underneath here and like make a little fort. And so what happens is cholesterol will form itself up underneath the endothelium. And you're like, oh, wow, okay. So this becomes a problem because now this is where we get a cholesterol streak or a fatty streak. And so think about it. You have this vessel. Let's just say we're looking at it from a different angle, right? These are the ends of the vessel. Now you have like this literal streak of fat in it, okay? And the original, let me draw it this way. You originally just had a little fatty streak or a little break in your endothelium there, and now you ended up with all this cholesterol building up underneath it. Okay, so now that's called a fatty streak. And then what happens is your body's like, oh my God, we're trying to fix this. So then it sends even more inflammatory stuff in there. So it sends like, oh, it's like, okay, we'll send more help. We'll try to clear out this cholesterol. Well, it tries really hard and it kind of hardens the area because of the inflammatory response. And eventually, hopefully, this will close up, okay? But notice the difference in the diameter, right? You ended up with like this really big lumen hole that blood could travel through to maybe half or even a third of what it once was. So this is like maybe, several months later. And you're like, oh, wow, okay, well, that's not good, right? When you decrease the lumen of a water hose, right, from an inch to a third of an inch, you're not going to have very much water coming out the other end. Well, in this case, it's blood. And so this is an example. This is an example of atherosclerosis, right? This is the plaque formation. That's the example of atherosclerosis. That's how this happens. If you're watching this video, this has happened in your body already. If you're a smoker, if you have diabetes, if you have high blood pressure, this is happening a lot worse, okay? High cholesterol, right? But really, diabetes, smoking, and high blood pressure are the ones that are very acceleratory for this. Excuse me, sorry. And so you're like, okay, cool story, Hunter. Why does this relate to cardiovascular disease? Well, I'm glad you asked. Well, if you have we'll talk about what this is, but if you were to have a blood clot break off, and it's like, okay, I'm just gonna plant it right here. Look how small the lumen is now, right? So where this little blood clot wedged itself right here, and then you have those little platelet guys, right? And they're like, oh, cool, blood clot. We like blood clots, so let's just start lining up on here and doing our thing and clotting and making a blood clot, right? Then you end up with like no passageway through this lumen. And then what's going to happen on the other side of that tube? There's no blood going through it. So the muscle that's relying on this tube is like, you're not like, where'd all the blood go? So you end up with chest pain or whatever symptom it is. You can have this in your legs or in your brain, in your kidneys, right? You can have this in a lot of places. But this is atherosclerosis. So let's see what the book says, right? So coronary artery. So again, this can happen anywhere in the body, but where we give a shit, especially, is in the heart and in the brain. But coronary artery atherosclerosis diminishes blood flow to the myocardium. Okay, interesting. Hunter just said that. Cholesterol and fatty substances form a plaque inside the walls of the blood vessels. Remember, a plaque will form. Remember, this is a plaque. That's a plaque. Okay, and then there's this other thing called arteriolosclerosis. And this is where it actually thickens and hardens. So these are related, atherosclerosis and arteriolosclerosis. Uh, but arteriolosclerosis is actually a little bit different. I'll explain this really quick. So arteriolosclerosis, you should know that this is most related to diabetes, okay? What happens is, well, yeah, we'll just use this. Just zoom in just on this, okay? We talked about atherosclerosis. I meant to put a picture in here on arteriolosclerosis, and I forgot, and I'm not restarting the video. So what happens is when you have high blood pressure or really diabetes, you can end up with called hyaline deposition into the coronary or into the arteries. So what happens is you'll have these little proteins that'll leak out of the blood, and they'll start lining up in the vessels. And when these proteins line up in here, it becomes thick and hardened, and it can decrease the lumen. And you're like, oh, okay, cool. So it's very similar to atherosclerosis, but it's not a plaque. It's actually protein deposition from long-term untreated diabetes, and smoking too can cause this as well. Don't smoke, guys. It's terrible for your heart. So anyways, that's the difference. So arteriolosclerosis, this word right here, or arteriosclerosis. Arteriolo actually means just small vessels, but arteriosclerosis, it's thickening and hardening of, right? Atherosclerosis is more plaque related. Both of these cause the same issue, narrowing of the lumen. The tube gets smaller on the inside, so there's less blood flow. Creates its own pathologies, right? But how they happen is just a little bit different. Now, can you have a patient with atherosclerosis and arteriolosclerosis? Absolutely. Like these are usually together, right? Diabetes and smoking, these are systemic damages done to the body. So just be aware of that, okay? Now, I talked about this a lot, so I won't rehash it too much, but our atherosclerosis, right? Again, normal artery cross section. And what happens in atherosclerosis is you get a little damage to the inside of here, you get a little Pac-Man coming in there, and then cholesterol, particularly LDL cholesterol, the bad cholesterol, will go up underneath there and be like, cool place to stay. And then your body's like, nope, can't stay here. So then more inflammation occurs. Eventually a plaque will form, and then it'll narrow the lumen of the vessel. So that's atherosclerosis is very common. This creates a lot of issues for a lot of Americans. Okay. Now, again, I talked about this thing called a thromboembolism. And you're like, okay, well, think about this. You can throw a clot. We talked about a pulmonary embolism, right? I'll just give you an example. We talked about a pulmonary embolism where you can get a little clot behind your knee, and it can lodge off and travel through your heart into your lungs and block the blood flow, called VQ mismatch, and then you can have some serious perfusion issues. But you could also get this in other ways, to where if you have a clot anywhere in the body, whether it's a blood clot or a piece of plaque or a piece of fat even, or whatever, that will launch off and travel, that's called an embolism. Okay, and a thrombus is a stationary blood clot, so that's why we call the one behind your knee a deep vein thrombosis. So remember, thrombus, sitting still for the time being. Embolism means it's moving. And so what can happen is these clots can form and shoot off or bust off and become a thrombus to an embolism, or they can just form a clot. Because remember, right here, there's a lot of inflammation taking place right here. And so if I were to zoom in on this, right, whoa, if there's inflammation here, platelets may inadvertently think, oh, wow, this is home. This seems like where I'm supposed to be. And so it'll start creating a blood clot here. And then before you know it, right, red blood cells and platelets and white blood cells, especially red blood cells and platelets, are like sticking to each other and clotting up like they're supposed to, like they're trained to. And so they end up clotting off this, okay? And so you can have a blood clot that will travel off at random and get stuck in a coronary artery. And, they demonstrate this here. Let's say there's a blood clot right here. Well, maybe not the color blue. That's not a good example. Let's say there's a blood clot right here. The muscle, the myocardium distal to that blood clot will die, okay? Or it's going to become ischemic and then eventually lead to infarction. Remember, ischemia, cells are starving for oxygen. Ischemia, infarction, the cells have died. And so eventually this is going to cause the heart cells to die. How does this present? Chest pain, shortness of breath, impending sense of doom, jaw pain, shoulder pain, arm pain, especially on the left side, right? These are all nausea. So these are all ways that this will present, okay? So atherosclerosis, major contributing factors, and these are actually, I should clarify, these are controllable factors, as in things that, I hate this, that we can mostly control. So these are called modifiable risk factors, okay? So they're claiming you control these. I think some of these are difficult to control, but that's whatever. Cigarette smoking, you can certainly control. Cigarette smoking is very, very bad for the vessels, okay? No surprise there. High blood pressure, I've covered with why. Elevated cholesterol levels. So if you have really high cholesterol levels, you're going to have a lot of cholesterol floating in the blood that's like, there's a streak in the blood, there's an opening in the endothelium, we'll just go up underneath here and hang out. So we try to decrease that with medication. Diabetes, diabetes with good exercise and medication, it can be controlled. It doesn't necessarily have to be out of control. And I should point something out. You hear me kind of quote, and I hate to use the word trash, but I talk about the damage of diabetes. It's because diabetes is very difficult to control. It's certainly doable. There are plenty of patients that control it. They're very strict on their diet and their insulin and their medication adherence. And they're very careful with their blood sugar monitoring, right? And that's what we want, right? Those are good patients. But there's a huge portion of diabetics that are not compliant, right? And they still eat whatever they want, and they don't take their medications as prescribed, or they don't buy their medications, or, they're not controlling their diabetes. And so, I should point out, diabetes is controllable, but it is very difficult to control, especially if someone doesn't want to, right? So just be aware of that. Lack of exercise, of course, that's modifiable and controllable, and stress. Sure, you might be able to control stress sometimes. Now, uncontrollable, or what they'll call non-modifiable risk factors. Age, older age, can't control that. Family history, you didn't pick your family. We all know that. Race, didn't pick that. Ethnicity, and the male sex. You didn't pick any of those things, right? Those aren't up to you to choose. And so just be aware of that. Men do have a higher risk of heart disease. Okay, not my opinion. Obviously, it's what the book says. Okay, and interestingly, what race typically has the worst coronary artery disease? I am pretty sure it's black men. It may be Caucasian men though, but it's certainly men. But I really want to say it's black men because they have really bad high blood pressure typically, and they can also have diabetes and obesity. So. Now, we're going to jump into acute coronary. Well, let me check one thing. Sorry, I just want to see if this is a good time for a break. Yeah, let's go through acute coronary syndrome and then we'll take a break. So break down the word. Acute means it's like sudden, emergent, it's acute. Coronary, we talked about the coronary vessels. These are the arteries that wrap around the heart and supply the myocardium. Syndrome. Okay, the vessels that wrap around the heart are acutely causing some issues. Acute coronary syndrome. You'll also hear this called, and I'm going to call it too, ACS, okay, acute coronary syndrome. And so it's like this big term that describes a systems consistent with acute myocardial ischemia. Okay, remember ischemia, the cells are starving for oxygen. And so myocardial ischemia can result, right, like what causes, right? Decreased blood flow in the heart. So if you have a heart rate of 35, cardiogenic shock, right, you're going to have myocardial ischemia. If you have, this can also result in, uh, I misread what they're trying to say here. Myocardial ischemia will eventually, because the pump won't be as effective, cause a decreased blood flow to the heart. So of course, if you have a heart rate of 35, that's going to cause a problem. But if, we draw the heart here and this whole section gets taken out, right? You're not going to be pumping very effectively. You just lost half your pump, right? So that is an example of, you could have decreased blood flow if this part of the heart is dying for oxygen, okay? And then it can result in angina pectoris or an acute myocardial infarction, okay? Angina pectoris is the fancy medical word for chest pain. I'll say that again. There's a slide coming up on it. Angina pectoris is the fancy word for chest pain, okay? So both treated similarly underneath the designation of acute coronary syndrome. So we don't spend a whole lot of time at the EMT level of thinking like, oh, why do they have chest pain? It matters on exams, but in the real life, it's very difficult to distinguish to where we found that, oh, someone has chest pain and we think it's cardiac in nature. It doesn't matter why they're having cardiac chest pain too much. We treat it. And so what we see is like, these just fall up underneath an umbrella called acute coronary syndrome. So it doesn't matter, like, it does matter, but it doesn't, like, we don't get too hung up on the exact cause of, okay, sorry, I thought my window was broken, of what's the cause of acute coronary syndrome. What's causing it is the coronary vessels are usually occluded, and we got to fix it, okay? So, well, next slide. Angina pectoris, right? The pecs, the chest, right? So it's saying chest pain. And so, and in fact, I call it angina. I've heard people call this angina, so be aware that there's different ways to pronounce that, okay? So this is, the thing about angina pectoris, right, is it's a brief period when heart tissues are not getting enough oxygen. So zeroing in on the word brief period, it's a period in time. It might be resolvable, but this is like an episode, right? That's could be, someone has a bad heart and they decide to run up 10 flights of stairs. Now they have chest pain. We would call that angina pectoris, right? That's chest pain, okay? And usually if it resolves, it means something. We're going to talk about that. So with angina pain or anginal pain, right? Angina, you can have this crushing, squeezing sensation in the chest, okay? And sometimes they'll just literally grab their chest like this. A lot of times they'll feel it radiating up into their sternum and up into their to their jaw, right? Their arm, their neck, and sometimes even their back or their epigastrium, right? So it's very vague symptoms because of the way it's innervated. That the body's just like, there's pain here, and this nerve's really pissed off, but it doesn't know like, oh, there's pain like right here, right? That's not really cardiac pain. It doesn't typically present. There's pain right here. That's musculoskeletal pain, right? You could use one finger to point to where your rib's broken. You usually can't use one finger to point to where your heart's broken, right? Like, well, not like broken, but like to where your heart's injured. So that's worth knowing, okay? The way the innervation works, it's very broad. So what they'll say is like, my chest hurts. They won't take one finger and be like, my chest hurts here. That's usually not cardiac in nature, okay? And the thing about angina, test question. Coming up on an exam near you, angina pectoris disappears with rest, oxygen, or nitroglycerin. NTG means nitroglycerin. What does nitroglycerin do? Increases venous capacitance, decreases preload, decreases the Frank Starling law, how much energy is required to contract, so you decrease oxygen demand, decrease chest pain, blah, blah, blah. Okay? So just be aware. You have to know. Angina pectoris is a brief episode of chest pain that disappears with rest, oxygen, or nitroglycerin. Okay? Angina pectoris. They also call that stable angina. Now, the reason we use this clinically is like, if someone runs up the stairs to their apartment and back down and they're having chest pain and they sit down in their car and they're like, okay, 2 minutes later, I'm good. I don't have chest pain, right? That's still angina pectoris, okay? And so what we have to know about this is like, oh, okay, this is the precursor. This is the warning before the storm that you're about to have a really big heart attack, or you could have a really big heart attack. So we have to take these episodes of chest pain seriously and look into it, especially as cardiologists or ER physicians or EMTs or whatever. You have to look into this and be like, oh, wow, patients having chest pain that's relieved with rest, there's something causing that, And we need to look into it to see if we can fix it before they have a full-blown heart attack and die or have heart failure, right? That's just almost as bad. So stable angina occurs as a relatively predictable frequency. Okay. So, for example, like say someone lives on a third story of an apartment complex, right? 58-year-old male has been smoking for 20 years, has diabetes. And they're like, oh, every time I go upstairs to my apartment, I get chest pain, but when I sit on my couch, it goes away 5 minutes. That's stable angina, right? Chest pain, it's exacerbated with exercise, relieved with rest. Stable angina, it's predictable. If you go upstairs, you're going to get chest pain, right? Um, as opposed to unstable angina occurs without a predictable frequency. So these are the people that are like, oh, I was in the shower today and I had like chest pain, but it went away. That's kind of weird. Um, or I was driving in my car and my chest hurt for like 10 minutes. Felt like an elephant was sitting on my chest. But I just kept driving and it went away, right? That's unstable angina. Like that's an issue, right? So when you have angina that's provoked really without a reason, or it's not predictable, or like, walking up 3 flights of stairs, oh, it's reasonable why someone with a bad heart would have chest pain. But someone that's like sitting in the recliner or watching TV or driving a car, without road rage, and they're like, oh, I'm having chest pain, that's an issue. That's like huge red flag of like, okay, there's something wrong with your heart. We need to look into this, okay? And progressive angina, obviously, what does progressive mean? To like get bigger, to generate, right? Like to get greater, I should say. This is angina that gets worse, okay? And again, these are all precursors to like the big ones coming, right? So, okay, let's take a break here and we'll finish this up. The next part, we're going to start talking about like acute myocardial infarction and heart failure and what sounds these make and what we look for and all that. So it's pretty exciting. I think you'll enjoy it. So, all right, that's it. Thank you.